Welcome to today's Nclex content review class, and today we'll be looking at abuse and neglect, and we'll be kicking off with child abuse. What's child abuse? Child abuse is that intentional, physical, emotional, even sexual misuse or sexual trauma, or even intentional omission of basic needs. When the child is neglected, usually it's related to a diminished or limited ability of the parents to cope with or even provide for or relate with their child. Um, so again, when you assess a child on the Nclex, what are you going to see? How do we know this child is being abused? One very key indicator would be when you have an inconsistency between the type of the injury or the location of the injury with the history that the parent is providing. So again, when there's inconsistency between the type or location of the injury, maybe a bruise or burn or a fracture, maybe a spiral fracture, is inconsistent with the history of the incident, that child might be abused. If you have unexplained physical or thermal injuries, the child is seen to be withdrawn or is fearful of the parents. You see signs of sexual abuse like genital lacerations or sexually transmitted diseases, or there are evidences of emotional neglect, failure to thrive, disturbed sleep pattern, change in behavior at school. Those could be signs that that child is being abused. So what do we want to do for this child on the Nclex? We want to provide for physical needs first. So again, remember, we want to address every physical need on the Nclex first before psychosocial needs. So physical needs first. Those lacerations, they are physical. Those injuries, they are physical. Physical before psychosocial. Again, mandatory reporting of the identified or suspected cases to the appropriate agency. We need to be non-judgmental of the parents. We want to encourage expressions of feeling, provide role modeling, and encourage parents to be involved in the care of the child. We want to teach them growth and development concepts, especially regards child safety, child discipline, age-appropriate activities, and even nutrition. We also want to provide emotional support for the child, like play therapy, dolls, having them to draw or making up stories. Those might be a more appropriate way for the child to express their feeling. We also want to initiate protective placement or appropriate referrals, especially for long-term follow-up. Again, documentation. When you are documenting as a nurse, you only want to reflect what you saw or what you were told, not your own personal interpretation of or your own opinion. So you want to only document what you saw or what you were told and not your own interpretation or opinion. With domestic violence, when you assess someone who's been abused in the home, you will notice there will be frequent visits to the healthcare provider's office or the emergency room for unexplained trauma. So again, there's going to be frequent visits for unexplained trauma. Most times you will notice that the client is being silenced or killed, or maybe the accompanying family member uh, keeps threatening the client. So that's another assessment finding you will see. There will be evidence of multiple old injuries or scars, or if you do an x-ray, you're going to be seeing old previous healed fractures on the x-ray. Again, there will be these fearful, evasive, or inconsistent replies, and even non-verbal behavior, such as, they flinch when you touch them or when you approach them. They are startled. Okay, so that's what we're going to see in this client. Remember that family violence is usually accompanied by brainwashing. So usually the victims blame themselves, they feel unworthy, they fear that they won't be believed. And some of the long-term effects of domestic violence could be depression, suicidal ideation, low self-esteem. They will have this impaired relationship outside of the family. And remember, women and children are the most common victims. What's our plan for a client who's been domestically abused? We want to provide privacy during the initial interview to ensure that the perpetrator of the violence does not remain with the client. You can tell the whoever you're suspecting is abusing your patient, please can you give us some privacy? This part is usually done in private so that they can step out and allow the abused victim speak up and speak out. Again, we want to carry out careful documentation of all injuries using body maps or photographs. Again, you want to get consent from the patient. Determine the safety of the client by asking specific questions, maybe about weapons in the home, substance abuse, is your spouse extremely jealous, and all of that. You also want to develop with the client a safety or escape plan. Okay, so we need to come and agree on how we can escape if we are in a tight zone or in a tight area. And you also want to refer the client to community resources such as shelters, hotlines, and even support group. With elderly abuse, that will be that single or even repeated act or lack of appropriate action that occurs within any relationship where you have an expectation of trust. So this will be causing harm or distress to that older person. So again, it could be physical abuse ranging from slapping or shoving to severe beatings. It could be neglect where you have intentionally failing to meet the physical, social, or emotional needs of the older person. It could be psychological. Here you see the caretaker giving the silent treatment or intimidating the individual by threatening the older person. Or it could be financial. With financial abuse, you could see misuse of funds to even the caregiver embezzling the client's funds. And also, what do we find when we assess clients who might be abused? Okay, so there's going to be evidence of battering, fractures, bruises, injuries such as cuts or even broken bones. You would also notice that most times they are over or they are under medicated. The caregiver can be over medicating the client so that they are sleepy and they don't have any job to do. There could be an absence of needed dentures. Or obviously, you see this client needs glasses, but again, she doesn't have one. So that could be elder abuse. You will notice poor nutritional status. You will notice dehydration. There will be physical evidence of sexual abuse. You will see urine burns. The skin might be excoriated. You will see pressure ulcers. You know, that signs of poor hygiene to let you know this elderly patient is not being taken well care of. Again, we could notice fear, apprehension, withdrawal from usual activities. You could even see symptoms of anxiety, depression, confusion. You will see withdrawal from family members or friends. So these could all be pointers to elderly abuse. And what's our plan for this client? We want to provide for safety, provide for physical needs first. We can't say this enough. Physical needs has to be taken off first. And you want to report to appropriate agencies. You want to initiate protective placement or appropriate referrals. Again, when you're making decisions for this client, you want to consider their rights to self-determination. So you want to ensure, remember the rights, the client has a right to make their own decision and choices. Ensure that your actions are respectful of the older person's wishes and rights. Again, you want to contact emergency services if there's an immediate risk of harm. And with sexual abuse, you would notice when we assess a child who is being abused, you would notice there will be disturbed growth and development pattern. The child will become protective of the parents. They would use defense mechanisms like denial, dissociation. You would notice sleep and eating disturbances. The child may be depressed. You would notice aggression, emotional deadening, almost like they don't react to emotions. You also notice amnesia, poor impulse control. We would see somatic symptoms like chronic pain, GI disturbances. You'll start noticing trancy, or the child may be running away from home, and they will have these self-destructive behaviors. With the adult victim of sexual abuse, we would notice the response is usually similar to delayed post-traumatic stress disorder. You will see nightmares like a client who has PTSD. They would have these unwanted, intrusive memories. They will have these flashbacks. You would notice they will have relationship issues, that fear of intimacy and abandonment. And with the sexually abused adults, we would also notice that they use defense mechanisms like denial, dissociation. They would also have relationship issues, abusive relationships. They would have fear of intimacy and abandonment, homicidal thoughts, violence. They could be hypervigilant. They suffer from panic attacks, phobias, agoraphobia, suicidal thoughts, even suicidal attempts. And what's our plan for these clients? We want to establish a trusting relationship. That's priority. We want to use empathy, use support, compassion, warmth. Remember, the nurse can just sit with the client as a form of support. Again, we want to carry out non-judgmental approach when we are dealing with these clients. We can engage in group and individual therapy. We want to appropriately refer this patient as needed. Again, we might need to place them on anti-anxiety medications. And like we said, you want to report to appropriate agencies.